Hi everyone. Today's topic is epidemiology. Learning outcomes. Explain aims, principles and terms of epidemiology. Summarize the requirements and uses of epidemiology. Describe the tools of measurements in epidemiology. Distinguish between incidence and prevalence. Categorize epidemiological study designs. These learning outcomes we are covering in two parts, that is part 1 and part 2. Coming to the term epidemiology, the term epi means upon, demi means people, then logy means study. It's nothing but upon people study. That means we are studying the people. Why we have to study that we will see in the further slides. So coming to the definition of the epidemiology, it is the study of distribution and determinants of health related states or events in a specified population and the application of this study to the control of health problem. I think this definition, no need of broader explanation. It is self-explanatory. Then epidemiology is the basic science of preventive and social medicine. It has evolved rapidly during the past 3 decades. Modern epidemiology has entered the most exciting phase of its by evolution by identifying risk factors of chronic disease, evaluating the treatment modalities and health services. The current trends of epidemiology, newer offshoots such as cancer epidemiology, neuroepidemiology, genetic epidemiology, occupational epidemiology, and psychosocial epidemiology, and so on. Coming to the history of epidemiology, first known epidemiologist is Hippocrates. First to tell no disease is sent by evils and demons, but it is the result of natural causes. Conceived relationship between habit, physic, weather, and disease. Then coming to founder of epidemiology, the name is Thomas Sydenham, a London physician, recognized as a founder of clinical medicine and epidemiology, emphasized detailed observations of patient and accurate record keeping. I think this is the first observation made and which is giving proper definition for the epidemiology by Thomas Sydenham. Then coming to John Snow, he is the father of epidemiology. According to him, careful mapping of cholera cases in East London during cholera epidemic of 1854 traced source to single well on Broad Street that had been contaminated by sewage. So these are some of the things about epidemiology. Then who is an epidemiologist? Any person who researches into occurrence of disease or disability in groups of people is called an epidemiologist. Coming to the qualification, an epidemiologist should be familiar with statistical techniques, well grounded in diagnosis of disease, through with history of medicine relating to the epidemics, then good knowledge of bacteriology, immunology, and physiology, then knowledge of principles of preventive medicine. So if you have all this qualification, then he can be an epidemiologist. Coming to epidemiologists need to know what they're supposed to know. They should know public health, clinical medicine, pathophysiology, statistics, and social sciences. Aims of epidemiology: to describe distribution and magnitude of health and disease problem in human population, to identify etiological factors in the pathogenesis of disease, to provide the data essential to the planning, implementation, and evaluation of services for the prevention, control, and treatment of diseases, and to the setting up of priorities among those services. The ultimate aim of epidemiology is to lead to effective action to eliminate or reduce the health problem or its consequences and to promote the health and well-being of society as a whole. Coming to the epidemiological approach, how we can approach for epidemiological studies. For example, asking question: what is the event? What is the magnitude? Where did it happen? Who are affected? Why did it happen? After collecting all this data by asking the question, then you can make comparison. What can be done to reduce the problem and its consequences? How can it be prevented in the future? What action should be taken by the community, by the health services, by other sectors? Where and for whom this activity is carried out? What resources are required? How are the activities to be organized? Epidemiological approach versus clinical approach. Coming to epidemiological approach, it focus is on group, but in clinical approach, it's focus on individual. In epidemiological approach, total number of cases, distribution, modes of spread, that is mass phenomenon. In clinical approach, we are going to check only signs, symptom, causes, and treatment of diseases in each individuals. In epidemiological approach, most important is pre-pathogenesis period. In clinical approach, it is pathogenesis period is most important. In epidemiological approach, concerned with environment in detail. In clinical approach, concerned with environment to a limited extent. In epidemiological approach, investigator go to community in search of suffering persons. In clinical approach, patient comes to doctor. In epidemiological approach, subject matter is conceptual, can be symbolized in the form of tables and graphs. In clinical approach, subject matter easily pursued by the techniques as clinical and laboratory examinations. These are some of the differences between epidemiological and clinical approach. What is the scope of epidemiology? It is also concerned with the study of general health status of human population in relation to the environment. Modern epidemiology concerns with not only the epidemic disease but also communicable and non-communicable diseases, namely cancer, heart disease, mental illness, dental diseases, congenital defects. Knowledge derived from the epidemiological studies is applied not only for the prevention of the disease but also promotion of positive health. Recently, epidemiologists have become involved in evaluating the effectiveness and efficiency of health services. Objectives of epidemiology: to collect and analyze all data relating to the roles of agent, host, and environment. To effectively describe the complete epidemiological situation. To analyze and describe the occurrence, distribution, and nature of disease according to the variables such as age, gender, occupation, season, and secular periodicity of occurrence of places and habits, customs, mode of living, which altogether constitutes social and geographical pathology of disease. To probe into the role of the causes at different stages where the disease as often are multi-causal and multi-phased. To help the administrator to channel their public health policies to serve the various groups of population, age, gender, occupation, rural or urban, to meet the felt needs of these groups in society they serve, to help lay down priorities and targets, to appraise their actions, and finally evaluate periodically to improve their social policy from time to time. Coming to the principles of epidemiology, the first principle is exact observation. The second is correct interpretation. Then rational explanation. Then scientific construction. So these are some of the important principles of epidemiology. Strategies of epidemiology. In order to deal with multiple problems, McMahon and Poe summarize the strategies of epidemiology. The first is descriptive epidemiology, that is description of the disease by time, place, person. Then the second is formulation of hypotheses, tentative theories. Third is analytic epidemiology, observational studies to examine the hypothesis, experimental epidemiology. The fourth one was experimental epidemiology. Coming to epidemiological triad, here we can see environment, then comes agent, then host. These three constitutes an epidemiological triad. Coming to agent factor, the dis because this is one of the thing in the triad. So in the agent factor, the disease agent is defined as substance, living or non-living, or force, tangible or intangible, the excessive presence or relatively lack of which may initiate or perpetuate a disease process. Classification of disease agents. It's biological agent, nutrient agent, physical agent, chemical agent. Absence or insufficiency or excess of factor necessary to health, like chemical, nutrition, lack of part of structure, immunological, and social agents. Coming to host factors. Demographic characteristics, example age, gender, and ethnicity. Biological characters, example genetic factors, biochemical levels of blood, immunological factors, and physiological function of different organ system of the body. Social and economic fact characteristics like socioeconomic status, education, occupation, stress, marital status. I think you will be knowing during your questionnaire study, you are going to collect all the data regarding demographics like name, age, gender, education, qualification, socioeconomic status. So these are some of the host factors we are collecting. Then environmental factors. Definition: the external or macro environment is defined as all that which is external to the individual human host, living and non-living, and with which is constant interaction. Classification, like physical environment, that is the non-living things and physical factors, example air, water, soil, housing, climate, etc. Biological environment, universe of living things surrounding man, including man himself. Some of them act as disease producing agents, reservoir of infection, intermediate host, and vector of disease. Psychosocial environment is defined as those factors affecting personal health, healthcare, and community well being that stem from psychological makeup of individual and structure and function of social groups. They include cultural values, customs, habits, beliefs, attitude, moral, religion, education, lifestyle, community, health services, social and political organization. Also part of social environment is the people. Component of epidemiology. First is disease frequency. Frequency of disease, disability or death Summarized as rates or ratios like prevalence rate, incident rate, death rate. It also concerned with the health related states or events in the community. That is example health needs, demands, activities, healthcare utilization. Distribution of disease refers to time sequences, place of occurrence, and person affected. That is time, place, and person. Determinants of disease are all the physical, biological, and behavioral factors. Terminologies variate. Any piece of information referring to the patient or his disease. Variate can be discrete, that is, present or absent. Example cancer of lung, broken leg, are continuously distributed. Example BP, serum cholesterol, height. Circumstances. Any factor in the environment that might be suspected of causing a disease. Example air, water pollution, etc. Come to the tools of measurements. There are three tools, namely rate, ratio, and proportion. Rates. Rate is the frequency of disease or characteristics expressed per unit of size of the population or group in which it is observed. A rate measures the occurrence of some particular event, that is development of disease or occurrence of death in the population during a given time period. It is the statement of the risk of developing a condition. Rate. Rate comprises the following elements like the numerator, denominator, the time specification and multiplier. The time dimension is usually a calendar year. The rate is expressed per thousand or some other round figure. That is 10,000 is to 1 lakh, something like that. Selected according to the convenience or convection to avoid fractions. Concepts of numerator and denominator. Numerator refers to the number of times an event, for example, sickness, birth, or death, has occurred in the population during a specified time period. The numerator is the component of denominator in calculating rate but not in the ratio. Denominator Numerator has a little meaning unless it is related to the denominator. The epidemiologist has to choose an appropriate denominator while calculating a rate. It may be related to the population, that is mid-year population, population at risk, or person time, or person distance, or subgroups of the population. For example, uh, COVID-19. What is the prevalence of COVID-19 means? For example, Malaysia is having 30 million population. In that, 50, 500,000 people are affected. So 500 is the numerator and denominator is 30 million. So always the numerator is related to the denominator. Then related to the total events like infant mortality rate, case fatality rate, and number of accidents per thousand vehicles. Various categories of rates. There are crude rates, specific rates, and standardized rates. Crude rates, these are the actual observed rates such as birth and death rates, also known as unstandardized rates. Specific rates. These are actual observed rates due to specific causes. Example, tuberculosis occurring in specific age groups. Standardized rates. These are obtained by direct or indirect method of standardization or adjustment. Like example, the death rate is equal to number of deaths in 1 year divided by mid-year population into 1000. That multiplier depends on the mid-year population. Example, in the study of diabetics, 100 of the 189 diabetic men died during the 13-year follow-up period. Calculate the risk of death for these men. Here, the numerator will be 100 deaths among the diabetic men. The denominator will be 189 diabetic men. And the multiplier is 100 because these both denominator and multiplier are in the hundreds position. So risk is equal to 100 by 189 into 100. We can't put 1000 here or 10 because multiplier has to be multiplied with the relevant to denominators. Ratio. Ratio expresses relation in size between two random quantities. The numerator is not the component of denominator. The numerator and denominator may involve an interval of time or may be instantaneous in time. Broadly, ratio is the result of dividing one quantity by another and it is expressed as x is to y or x divided by y. Example, number of children with the scabies at certain time divided by number of children with malnutrition at certain time. Here, numerator is not a part of denominator and vice versa. Example, Delaware's infant mortality rate in 2001 was 10.7 per 1000 live births. In New Hampshire, infant mortality rate in 2001 was 3.8 per 1000 live births. Calculate the ratio of infant mortality rate in Delaware to that in New Hampshire. So we can calculate very easily. 10.7 divided by 3.8 into 1 is equal to 2.8 is to 1 between Delaware and New Hampshire. Thus, Delaware infant mortality rate was 2.8 times as high as New Hampshire infant mortality rate in 2001. Coming to the proportion, a proportion is a ratio which indicates the relation in magnitude of a part of the whole. The numerator is always included in the denominator. Proportion is usually expressed as a percentage. So here the multiplier is fixed, that is 100. Number of children with scabies at certain time divided by total number of children in the village at the same time into 100 because you are going to calculate the percentage. Example, calculate the proportion of men in the NHANES follow-up study who were diabetic. Now, NHANES is the hospital. Here the numerator is 189 diabetic men, denominator the total number of men is 189 plus 3151. So it will be 3340. Proportion is equal to 189 divided by 3340 into 100, that is 5.66 percentage. Coming to the basic measurements of epidemiology, it includes measurement of mortality, morbidity, disability, and natality. Coming to mortality rate, especially the infant mortality. An infant death is the death of live-born child before his or her first birthday. That means less than 1 year. Deaths in the first year of life, that is neonatal before 20th day of life, post neonatal between 28 and 365 days of age. So if we ask what is the difference between neonatal and post neonatal, this is the difference. If the baby is dying before 28th day of life, that is neonatal, and if it is dying between 28 and 365 days, that is post neonatal. Come to infant mortality rate. An infant mortality rate is based on periods calculated by, example, dividing the number of infant deaths during a calendar year divided by number of live births reported in the same year into 1000. That multiplier depends on denominator. Example, 1300 infants death in 2008 among the state residents in 1,50,000 or 150,000 live births in 2008 to state residents. So if you substitute in this formula, you will get the answer. So uses of measurements of mortality. In statistics, like to know the cause of death are important and widely used for number of purposes, like it will explain the trend. For example, in 2001, uh, maybe for example it will be high, after that 2020 it will reduce, like that it might give, it will give the trend. excuse me, and it will indicate the priorities of health action. For example, in some area there are more people dying due to some disease. So we can fix or we can prioritize the location, and depending on the age group or depending on uh, their workforce, or like depending on their working environment. In designing intervention programs, in assessment and monitoring public health problems and programs, they give important clues of epidemiological research. Limitation of mortality data. Incomplete reporting of deaths, because some countries they won't measure the death only. They don't have standard protocol to report the death. So we will lack of accuracy and lack of uniformity. Then choose a single cause of death. Sometimes, see, nowadays people choose only COVID is the cause for death. They don't want to specify what is the main cause for death. Then changing coding system, then disease with low fatality. The commonly used measures are crude death rate. Here you have to remember what is crude. It's defined as number of death per thousand estimated mid-year population in 1 year in a given place. So crude death rate summarizes the effect of two factors: population composition and age-specific death rates. The disadvantage of the crude death rate is they lack comparability for communities with population that differ by age, gender, or race. I will explain you what is the disadvantage. For example, we can tell the mean DMFT of Malaysian is 3.4. Here I am not specifying which age group. For example, 12-year age group, the mean DMFT is 3.4. That means that will have some meaning. So we can concentrate on 12-year age and we can conclude it. But if I am telling broadly, the mean DMFT of Malaysian is 3.4, that won't give exact meaning. It might give, but it is not specifying which age group or which race. So crude death or crude rates are have that disadvantage. The specific death rates, like the cause are disease specific, like tuberculosis, number of people are dying, or cancer, number of people are dying. So specific to the specific disease. Then related to specific groups, related to any other variables such as income, religious, race. So we expect specific rates. So that will be useful, and it will prioritize the disease or gender or location. Then the uses of the specific death rate is specific death rates can be help us to identify a particular group. They permit comparison between different causes within the same population. So how you can calculate? Number of death due to tuberculosis during calendar year divided by mid-year population into 1000. Then case fatality rate. It represents the killing power of disease. For example, in the COVID, see, nowadays we can take ideal example COVID only. Whatever reason, most of the things will apply for COVID. Represents killing power of disease. It's simply the ratio of total number of death due to particular disease divided by total number of cases due to the same disease into 100. Here the time interval is not specified. Uses typically used in acute infectious diseases like food poisoning, cholera, measles. Its usefulness in chronic disease is limited because the period from the onset to death is long and variable. It is closely related to virulence. Case fatality rate for the same disease may vary in different epidemics because of change in the agent, host, and environmental factors. Coming to proportional mortality rate, that is ratio, it is given by number of deaths due to particular cause in a specific age group divided by total death into 100. The use of proportional mortality rate is to compute for broad disease groups such as communicable disease as a whole, and for a specific disease of major public health importance such as cancer or coronary heart disease. Used when population data are not available, and useful indicator within any population group of relative importance of the specific disease as a cause of death. Limitations. Since it depends upon two variables, both of which may differ, it is of limited value in making comparison between population groups or different time periods. It does not indicate the risk of members of population contracting or dying from the disease. Coming to survival rate. It is a proportion of survivors in groups studied and followed over a period. See, survival rate we can calculate for our survival of restorations also. For example, today we have done the restoration. After 6 months, that restoration might break. So how long it survived means 6 months. So same thing. The total number of patients alive or restoration divided by total number of patients treated into 100. So uses of survival rate is for describing prognosis in certain disease condition and yardstick for assessment of standard and of therapy, then special attention in cancer studies. Survival rate is usually reckoned from the date of diagnosis or start from the treatment. Measurement of morbidity. Morbid means it's a sickness, the person who is suffering from sick or who is a sick. Any departure, subjective or objective, from state of physiological well-being. The WHO Expert Committee on Health Statistics noted in its sixth report that morbidity could be measured in terms of three units. Persons who were ill, the illness period or spells of illness that these persons experienced, the duration, days, weeks of this illness. Measurement of morbidity. It can this is three aspects, namely frequency and duration and severity. Disease frequency is measured by incidence and prevalence. The average duration per case, which is average number of days of disability per person, gives measure of duration of illness. Case fatality rate may be used to index of severity. So now we will go study the frequency measure, that is incidence and prevalence, in the further slides. So uses of morbidity are they describe the extent and nature of disease load in the community. The second use is they usually provide more comprehensive and more accurate and clinically relevant information on patient characteristics than can be obtained from mortality data and are therefore essential for basic research. They serve as starting point for etiological studies and thus play a crucial role in disease prevention. They are needed for monitoring and evaluation of disease control activities. Coming to incidence, the number of new cases of specific disease occurring in defined population during specific period of time. Here two things I will be stressing: specific disease, specific period of time. So the incident rate is this number per specified unit of population. Then what is incidence rate? Incidence rate is nothing but number of new cases of specific disease during a given time divided by population at risk during that period into 100. For example, 590 new cases of oral cancer reported in population of 7,500 or 75,000 in a year. The incidence is, according to this formula, 590 divided by 75,000 into 1000, because denominator is in 1000, so multiplier is 1000. So the uses that will be around 7.87. So generally restricted to acute condition. For example, like cholera, even COVID, it was acute at one moment. So coming to different types of incidents: episodic incidents, cumulative incidents. Episodic means the rate of occurrence of new episodes of disease arising in population. This can be usually applied to conditions where previous episodes may only be weekly reported. Coming to cumulative incidence. Similar to incidence, but the time interval is expressed as a fixed period and results in expressed as a proportion. Types of incident rates. In that, first is the attack rate. It is an incidence rate which is used only when the population is exposed to risk for a limited period of given time, as in the case of an epidemic. Attack rate gives information on number of cases at risk. Secondary attack rate. The number of persons exposed to the risk factor for developing the disease within the range of incubation period following exposure to primary case. The number consists of number of cases of disease which occur within the same household following the occurrence of first or primary case. It is used in studies of infectious disease. Typical example is COVID. So uses of incidence. It is useful for taking action to control the disease. It gives clues to research into the etiology and pathogenesis of disease. It helps with the study of distribution of disease. It is useful in evaluating the efficacy of preventive and therapeutic measures. Coming to prevalence. It indicates all current cases, both old and new, existing in given population. So it can be calculated like the total number of all individuals who have an attribute or disease at particular time divided by population at risk of having the attribute of disease. It is expressed as percentage of population and can range from 0 to 100%. Types of prevalence. First is point prevalence. Point prevalence of disease is defined as the number of all current cases of disease at one point in time in relation to defined population. The point in point prevalence may consist of a day or several days or even few weeks depending upon the time it takes to explain the population sample. Point prevalence. Number of all current, old and new cases of specified disease existing at given point in time per estimated population at same time into 100. Point prevalence can be made specific for age, sex, and other relevant factors or attributes. So this is an example like how to calculate the point prevalence. So limitation of the point prevalence is not the ideal measure for studying diseases, etiology or causation of diseases. Because for example, if you check, we have gone for a camp and if you check dental caries, at that moment we will see only dental caries. But if you follow the same sample, we can see how many of them will have new dental caries over a period of 6 months or 1 year. So this will give only burden of disease, but etiology or other things we can't check from the prevalence. So incidence is good, but it will take time. So to check the incidence, you have to do a quad study or a longitudinal study. For prevalence study, we can finish off with cross-sectional one. So that we will discuss in part 2, like what is cross-section, what is quad study and all. Then period prevalence. It measures the frequency of all current old new cases existing during a defined period of time expressed in relation to a defined population. Period prevalence. Number of existing cases of specific disease during a given period of time interval divided by estimated mid-interval population at risk. So uses of prevalence. Prevalence rates are useful in estimating the magnitude of disease or health problems in community, in identifying the potential high-risk population, useful for administrative and planning purpose like assessing manpower needs in the health service, hospital beds and rehabilitation facilities, etc. Limitations of prevalence rate. It's not ideal measure for studying disease etiology. That I've already told you. So relationship between prevalence and incidence. See, you have to remember this. P is equal to I into D. P is the prevalence, I is the incident, and D is the duration. And if you are good at mathematics, you can cross multiply and you can produce your own things like I is equal to P by D, D is equal to P by I. So if you know some values, we can find other values. It's just a mathematics. So factors influencing the prevalence rate. See, prevalence I have already told you both old and new. So longer duration of disease because if the disease is longer, so prevalence is increase. Whenever you check, the disease will be present. And prolongation of life of patient without cure, this both are same only. Longer duration of disease or no treatment, it will be prolonged. Then increase in new cases, yes, again it increases the prevalence. Then migration of new cases, again it will increase. Out migration of healthy people, then in migration of susceptible people, improved diagnostic facilities. So prevalence is decreased by shorter duration of disease, high case fatality, decrease in new cases, exactly opposite to the previous slide. So if you remember one, you can write the other one. Thank you.